Hello, all my friends out there in the Dinks world. How are you tonight? It's Wednesday, and that means it's Hump Day. And that means it's also time for Humpday Happy Hour with Dentists in the Know. This is your backstage pass for current trends, politics, and education in the dental world. It is live. We are now on YouTube and coming back into the fold on Facebook later and on podcast and wherever else you might pick us up. Anyway, my name is Dr. Jeff Horowitz. I am usually joined by Dr. Chad Duplantis and Dr. Jennifer Bell. Both of them have decided to go on summer break. I don't know if they're ever coming back. So they've just left me to hold the fort down. So can't promise what's going to happen. Can't promise if it's going to be good. Can't promise if it's going to be bad. But I'll tell you what, I think we're going to have some fun. Anyway, I have one of my heroes, I would say, in dentistry, with to know him as we were in the same lecture get together in the sleep world. His name is Jerry. Aside from being one of the most intelligent people I have ever met, he is just so dedicated and doggone it, what a nice guy. You can't not love Jerry Hugh, and I sure do. So tonight's going to be a little bit of a love fest. It'll be a little bit of a nerd fest, but we're going to talk everything sleep apnea, OSA treatment, airway, TMD, how to finish these cases. We're going to talk about orthotropics. We're going to get into everything. So even though we don't have Jennifer for the news tonight and we don't have our usual dialogue at the beginning, I honestly think we're going to have probably 45 to 50 minutes of some best conversation I've heard in a long time. That's no my part in crime. It's just when we get nerd on this, really get fun. Knows what's up. Anyway, as you know, at Dentists in the Know, we are all instructors, we are all educators, we are all business owners, and most importantly, we are all dentists. Our job is to bring all of you in the know. I'm so excited to be here tonight. Without further ado, I'm going to bring my friend Dr. Jerry Hugh up. There he is. Hey, Jerry, how you doing?
Hey, good. I'm so happy to be here, Jeff. I was actually blushing when you were introducing and talking about me. So let's get that love going and get the conversation going.
there you go. I love it. So maybe, I hope I'm saying this right. You are from Soldotna, Alaska.
You got
Soldotna or Dotna?
It's Soldotna. You hit it just right. It's Russian and soldier in Russian.
Oh, very cool. And so let's start there. How does a boy from Alaska get this deep into dentistry and all the education that you've done? And you know, now for those of you who don't know Dr. Hugh, he is actually in Las Vegas now with a beautiful multidisciplinary center where he's focusing on airway and TMD and orthotropics and everything you can think of, including cosmetics. So tell us that story. How did that happen, Jerry?
So, I was actually born in Taiwan, and my folks gave up their career so that my brother and I can have opportunity in the U.S., right? The American dream. And so they went into the restaurant business, and we were first in San Francisco Bay Area for about a year or so. And they did fine, but a golden opportunity came for them to go to Alaska. So I was actually raised in Alaska in small town, remote. And I find it's almost like a calling, because oftentimes, a lot of dentists and people may say, well, because you're in a remote area, you can't do things that are either up to date or state of the art. And, I said BS to that when I was young, because it actually made me more motivated to really dive into everything from cosmetic, implant, and of course now dental sleep medicine. Also the fact that it was small town, it was really almost a blessing, because when you follow through the cases and you are, really connected with those patients. I imagine it can be that way anywhere, right? But in a small town, everybody knows each other. So yeah, I grew up there. I went to school in Michigan, and I went back because the practice I took over, it was my English high school teacher's father who had a practice there 37 years. And when he was practicing, it was actually the territory of Alaska. It wasn't even a state yet. And so it was really cool because he would tell me stories about him getting patients on a raft up the Kenai River. And as they went down river, you would extract teeth and bring on other patients, and they would kind of walk home, or people would do a day's journey to visit him for an extraction or some restorative work. But it was really cool, and I was able to do that. And it's been over definitely well to the 26th year now. I still have my practices up in Alaska because that's my connection forever. But I'm really also very happy to be in the Vegas Valley, because Vegas is now estimated to be over 3 million. And so if you think of the state of Alaska, you have about 750,000 people, and just this one city in Nevada, right, has more than quadruple the number of people. And so in terms of my being a part of moving the needle forward, or addressing people, in terms of population size more effectively. And also for my kids' education, there's a lot more opportunity in the lower 48. So, my kids are going to school here in Vegas as well. So, yeah, I just look back, and I think, honestly, it's just really like a blessing where God's kind of put me in places, and I hope, again, I can be an instrument or a tool to help all of dentistry, as well as, this whole issue of awareness in sleep apnea.
Well, tell me, 'cause that's amazing. I don't think I realized that there are not a million people in all of Alaska.
Correct. Not
I
even
did not, honestly. Now, people may call me ignorant for that, but I really had no idea that there were not a million people in the entire state. I mean,
but
that is a lot of geography.
yeah, yes. Go 500 miles and you're still in the same state. But we did beat Wyoming, so we are no longer the least populated. I think there are fewer people in Wyoming, so we
There
can.
you go. There you go. So you got that going for you. But tell me a little bit about how did you start your practice in Alaska, and tell me the evolution there, and when you started getting into deeper continuing education, because it would be so easy in a rural area just trying to meet the most basic of needs,
Yeah,
for that patient population. And we know how underserved a lot of that community is. So I would think just meeting basic needs would make it difficult to even find the time to go out and build your education and your wealth of knowledge.
Yeah, so I think you nailed it right there. I think, again, earlier, kind of was alluding to the fact that we are very rural, but I just didn't want that notion to be sort of an obstacle or a hindrance for me to really dive in. But when I went through dental school, I had a wonderful training education in Michigan. However, there's just a lot of concepts, especially when you touch on TMJ and inclusion. And right when I got out, the extreme makeover shows, the smile makeover was such a big, part of our contemporary society back then. So it's our past history. But anyway, so when you take on those cases, oftentimes you're kind of married to the patient. And so when you think about, from veneers to even full mouth reconstruction and all that, to do it appropriately, you really need to kind of dive in fully, right? And so at that time, of course, there's so many different places. Hanky to LVI. Coist wasn't as big, in early on in that time frame. But I started doing these smile makeover cases and stuff like that. But sometimes when there are occlusion issues or when there's pain, you get kind of just a dabbling of that, if you will, at dental school. So I said to myself, you know what? Although, albeit I was in a lot of debt out of dental school, but I said, I owe it to the patients really to give them whatever the lower 48 calls as contemporary or up to date. I think my patients deserve that. So yeah, that at first initially took on more debt, but in the end it really paid off because I really wanted to dive into nathology, occlusion, TMJ. And so from that, that was kind of an era of smile makeovers, right? And so the American Academy of Cosmetic Dentistry, They were a very, very good body of academy. They have the 89 criteria that they use, from axial inclinations to polychromatic, opalescence, et cetera, criteria that they use for their cases. And, I worked with a wonderful lab technician to get him accredited with AACD, or he used all of my cases and stuff. But that part and the part about occlusion, right? Because you can put so much beauty and thought and art into cosmetic dentistry. However, what about things like sleep bruxism? What about things like airway issues, right? And actually, I did kind of jump a little bit forward with that, because in between that was the implant revolution, or the implant, right?
Right.
Implant, I said to myself, well, gosh, and actually that was very, very key, because when I went to the implant world, every time they talked about bruxism and what are implant failures, right? They first I said, oh, well, implants are invincible, and if you do anything but implants, you do those fixed bridges, you're borderline doing malpractice. I'm like, excuse me. But later they're like, well, yeah, now there's periimplantitis, perimucositis, and then what about the long axis of the implant and the load, and you have issues with that. So it was very interesting, because I had a patient who came in already partially edentulous, and she had a lot of root tips. She actually clinically fractured. Of course, there are those classic gap fractions, sleep bruxism from hell. And at that time, I had no idea about airway, right? I had no idea how airway is connected to so much and is the root cause of so many things that we, as restorative dentists, as cosmetic dentists, as implant dentists, really should be focused and also looking at as well. And so this partially edentulous patient, I said, well, okay, I'm going to go ahead and, start, because you have, edentulosum, functional deficit, removing your root tips. And then, I'm very by the book. So at that time, they came out with the Nobel Active. And of course, there was, recommended times of osseointegration and healing. And so, of course, after the bone grafts, I was always by the book. I let the healing take place. Any type of major surgery is always done by the oral surgeon if there's an oval window, but some sinus tinting and stuff like that, minor surgeries I did for bone grafting. After that, I always waited at least 5.5 months for osseointegration for implants. And so at that time, I had no idea about sleep or airway, right? Everybody bruxism and stuff like that, but they're not really a big dental sleep medicine type of interest. So I'm not kidding you, okay? So I restored Nobel Actives, okay? And the teeth were restored and in function for 1.5 years. And so a lot of my lectures actually show the radiographs and the actual photos. So this patient, after 1.5 years in function, right? It's already osteointegrated. It's on the long axis. I made it slightly out of occlusion. I made sure there was no torque, no class 1 through 4 interferences, et cetera, et cetera. And this patient came up to the office in the morning, and she opened her hand, no appointment, unannounced, and oh my God, it wasn't the abutment or the crown. It was actually the entire half of the fixture, the implant fixture, the bone, the soft tissue. And so she freaking fractured the implant fixture, right? And I said to myself, excuse me, like, what happened? And then I look at her photos and for her original, records. I'm like, oh my God, you really have freaking forces up the wazoo. Well, then I said to myself, I said, well, I did everything I could to kind of take it out of occlusion, light occlusion. But you and I know, Jeff, like, excuse me. So if you have severe sleep apnea, and whether you don't even have to be necessarily on your back or supine, you could be kind of sideways a little bit, and you're in REM, body's paralyzed, tongue falls back, your body's trying to survive, it's trying to fight for a patent airway, and it could be pitch, it could be roll, it could be yaw, it could be diagonal forces that normally, if I go like this, and you occlude, it's going to be different than I go like this or with my head up, you know what I'm saying? So those things kind of made me have an aha moment that say, holy crap, like, everything that I do, if I do veneers, if I do implants, if I do all on 4s, all on 6s, if you're married to the patient in that way, hell yeah. We want long-term success, long-term survivability of what we do, right? So doing the bread and butter, doing just the basics, if you will, just wasn't going to cut it, right? Especially in your small community, small town, that actually was a good thing because, rumors and things spread quickly. And if I do these kind of half-butt cases, if you will,
definitely, yeah, the word will get out quickly.
So after that, I really had some other I think kind of what you call serendipity or things that have happened to me where my parents, and it's okay. I'm not really past the morning. I lost my mom the day before my birthday last year, and then I lost my dad 2.5 years ago,
I'm
and
sorry.
yeah, no, but the thing that I think is again is so kind of meant to be in a sense that it gave me even more deeper passion is the fact that their systemic issues and problems, and of course with their sleep bruxism and other things that are related to our end of the world. But so my dad had Alzheimer's, dementia, and congestive heart failure, so he did have the classic Cheyne-Stokes breathing, and he had those issues, but I couldn't believe the number of primary care physicians, all the way to his neurologist and cardiologist, that they did not, first of all, take sleep seriously, or also know about all the pros and cons with CPAP, as well as just the whole idea that so many of the root cause, if you will, and everybody kind of knows and accepts it now that pretty much going through medical school and including residency, first of all, there's very, very little training on sleep, maybe 2 hours of elective, first of
Absolutely.
all. Yeah, but moreover is kind of, I don't want to say this, I may get in trouble, is big pharmaceuticals. Big pharma has control of everything. I don't care if you're a kid on Ritalin or Adderall, all the way to adults on
Yeah.
so many different medications that come with a whole slew of side effects, right? And then for my mom, that's the thing, 40 years of hypertension medication that built upon, right now it's kind of funny if you talk around to a lot of people who are recently diagnosed with hypertension and you look at the medications they're taking, it's always the same ones, the same
Yeah.
ones for these. So my mom's kidney, of course, after 40 years, were shot. So she had to be on dialysis because she had full kidney function failure, no function, right? So on dialysis, the 2 days before my birthday, she flew down to Vegas. We have a birthday celebration. Well, during dialysis, they took way, way too much fluid out, and so electrolytes, everything went off balance. So unexpectedly, she had a heart attack and died in the middle of the night.
Oh
So
gosh, how
this
horrible.
kind of things where it makes it real like, well, like, at first you're just like, oh my god, like why what's going on, why is there so much lack of knowledge and awareness? But then again, it's like, well, and I'm not trying to think like there's anything that I'm supposed to be a person who moves the needle forward thing, but there has to be something that gives me the energy and the drive, because Jeff, it's these are my parents. My dad was my hero, and I'm freaking pissed. I'm pissed about the lack of communication, the lack of knowledge, the lack of awareness. And so when I talk about sleep, I get really passionate because it really hits home hard. And myself, I used to be almost 400 pounds. Of course, we're talking about leptin, ghrelin hormones, talk about energy. After I addressed my own sleep apnea, right, I was able to have not just the energy, but I got my black belt in karate, and there was like these tests, these endurance tests. They were just no way in hell, being 400 pounds, that I could have gone through them. The last one was 8 hours, and it was nonstop ninja crunches, nonstop burpees, and it's the like not ninja, but my sensei was kind of like
Yeah.
ninja. Anyway, he spat in my face. He says, "Jerry, do you want that black belt? Do you want that black belt?" And I'm like, yes, sensei, yes, sensei. And I'm like, the next 2 days, I couldn't even walk. I was so like over lactic acid buildup, whatever you call it, But I
Yeah.
felt, and it says to me again, like, you know what? Sleep is so dang important, and sleep tied to everything from our quality of life to even as dentists or restorative dentistry, like that implant case where other issues. I actually had another lady that had an overdenture. She moved to Alaska from New Mexico, and the same thing happened. She actually fractured bone with the implant in half with soft tissue. It was just like, holy crap, right? The forces that can happen night after night after night when the body is desperate to survive. Those are really, really important things that I think we as dentists really need to look at. And by the way, I mean, if you're a very, very kind of guideline or by the rules kind of dentist, then you think about the 2017, whatever the 88 protocol saying every dentist should screen and actually look for airway. And if they don't treat or do it, they should do the proper referral to someone, who can do so. And I think it's so important.
I agree. And you hit on so many great points here. The first being when you were talking about when you were so overweight. And And the fact that, because I've been in that, I've gone through that same journey. Now, I did not get my black belt, but there's something that has to break that cycle. And this is what a lot of people, I think, don't really understand about OB, is it's not just go on a diet. It's
Right.
not just exercise. Something has to break this horrible
Yeah.
circle that you're in, because when you're not sleeping, and you talked about the hormones leptin and ghrelin that get way out of whack, so you're always hungry. It's why people in shift work are always wanting to eat and snack. You're just always hungry when you don't get enough deep sleep. And likewise, when you do eat, you never feel satiated. So just having those two hormones out of whack, you're not getting good sleep because you're apneic. You have no chance in hell of ever completing a diet of any kind. You can't tell someone like sleep apnea that is that overweight, just go diet, or just exercise for them. Their blood is out of whack. There's so many things going on systematically that until we regulate sleep, it's such a critical piece. And it's why, so I went the easy route, Jerry. I had gastric sleeve surgery. I did what a lot of Americans do. I took the easy path. Now, I tried a bunch of times before. I was already treating my sleep at that point, but I took the easy road and I did gastric sleeve. But what really impressed me were, going through this with a lot of other people in the community was really a kind of a crazy time, because I really gained an appreciation for how hard a lot of these people have tried, how much and how we have been saying to them, just lose weight and all of your other problems get better. And that's not the case.
Right.
So you cannot ignore sleep and expect that systematically somebody, or physiologically, that they are still going to thrive. Something will still be off. And until you restore that common denominator of sleep, it's always going to be a hard time. So, and that's, I'm sorry, go ahead.
Yeah, Jeff. I mean, first of all, when it comes to our own health, I don't believe there's any cheating whatsoever. We live one life, and so what if you had bypass surgery? So what if you had anything that you've done? If it gets to a point A to point B and you're healthier and you're able to contribute to society, to your family, to your happiness, if you will, to me, it's never cheating. It's all good. And I think it's so important, because look at our society nowadays, right? With so many things that really tear. We have depression, mental illness skyrocketing. We have anxiety. We have so much inflation, economy, pressure, job, so many things going on. And
now I'm depressed, Jerry.
you know, but what I'm trying to say is whatever we can do. But also, if you think about what is the antithesis of a lot of these, things that we do to make us feel better. Well, to be honest, to be forward, it really is a combination of the food industry, of big pharmaceuticals, of money, of companies and executives and people who actually don't give a crap, or maybe they want world depopulation. Who knows? I don't know. But it's really interesting that things that actually really work in our quality of life improvement, it's not out, with a big trumpet sounding board all over media. And it should really be, because, if we really are true to ourselves, and, as dentists, we have our Hippocratic oath. I mean, we have to not just do no harm, we have to do everything we can to, help improve the patient's quality of life and health. And so I just wanted to add, though, but sorry for interruption, but because it's really a lot of people, I think, do some shaming on social media. And I think that's a bunch of baloney. I mean, you know what? So what if someone got surgery? Look, they're healthier. They're enjoying life better. They're able to do sports and activities better. So shut the hell up. I'm sorry, So anyway.
No, I agree with you. And please don't take that as I'm knocking the surgery. You know, and even now with a lot of these weight loss medications that are out there, you know, I think some people, it is a great first step. My point is that where I think we fail is in the education of our patients to say, look, there's no one thing that's going to fix you. There, you know, you need to consider lifestyle. You need to consider sleep. You need to consider diet. You need to, there are so many other things. And you know, I see people who had the procedure that I had that gained all the weight back. I see, you know, people who, you know, are going on, you know, the Ozempic and Mounjaro and all these kinds of medications. And the second they go off, what do? They gain it right back. And I really feel like it's because we're offering this as a solution as opposed to as a tool to say, okay, we're going to do something to break the cycle here. Now, here are the things you need to maintain this. And I think that's where we're really failing as a society.
I absolutely agree, and I think you know, when you brought up Ozempic, and again, you know, of course, it leads back to the big pharmaceuticals and stuff. I mean, if you actually even look at the price of stocks, you know, of what associated with those, wow, okay, but you know, and I guess that the thing is maybe from the get go, our education really should be. I mean, I look at some of the Scandinavian countries as well as in Netherlands and Denmark. So we had a group of dentists that came up to Alaska one time, and they wanted to do both cosmetic dentistry and dental sleep medicine. And I know I went about maybe 2.5 hours in the cosmetic dentistry component, and at the break, you know, a couple of people say, "Hey, you know, it's awesome stuff, but we really want to know more about, you know, sleep medicine." And so I started, you know, talking about sleep. And you know, one thing that's even very, very like everybody knows but don't talk about is our hours of like school time. They suck. It's in the literature. Okay, anybody you talk to who's an expert in sleep will tell you that no, we should probably, like, in those countries, start maybe 10 or 11 a.m. instead of, like, you know, getting into the school bus part at maybe 6 or 7 a.m.
Right.
And then also, if you're at a school like in Asia, they do napping. They do naps in the middle of the day. And well, you think about test scores, you think about standardized issues and how America's education, everything like that is so far behind. I mean, it's just been a freaking uphill battle since like kindergarten, grade school. Everything from the timing, your circadian rhythm, all the way to our diets, you know. And if you think about that, I mean, I can get into detail about those issues, you know, even with like C-section babies, about microbiomes, about the flora, and about how many, you know, and if you think about it, the neurology in our brain is not really that much more than the neurology of our gut, right? So our gut with the microbiomes, oh my God, holy cow. And the things that you feed or the allergies that persist in combination with airway issues as your body are compensating for things is really like, you know, even the food pyramid, I mean, you know, about issues
Yeah.
left or whatnot.
That's been the biggest joke in America for
Yeah,
how long now?
yeah,
And
right.
and they still don't have it right.
Yeah. And so I don't want to say like I'm like crazy or nut or conspiracy, but you know, for so many years, these are actually evidence based. You know, there's actually documentaries all over different, you know, from Netflix to Paramount, whatever, that talk about these issues and these studies worldwide about nutrition, digestion. But you know, even as a child, if we're not properly breastfed, you know, there's some studies that show even westernized breastfeeding where you hold the baby sideways versus koala hold when you're more like, you know, aboriginal cultures and tribal
Mhm.
people, you know, you find that in their lifestyle, their diet, and you've nailed it, they grow up with beautiful functional craniofacial development that doesn't create all these airway issues. And then of course, if you're in, like, you know, aborigine area in Australia, for example, you're probably not going to have orthodontists that kind of remove teeth and dystalize certain things.
Right, right.
And I don't want to be a touchy subject, you know. There's a lot of things that we do here, and it gets me so much. like confused or angry or frustrated when I know every freaking person who has a DDS or DMD or call themselves a doctor have an oath, right? And if you know better, either just stop doing more harm, okay, or just freaking learn about how you can make treatment and quality of life better for your patients, right? So it really, and yes, people say, well, it's just mainstream, or it's just the media, or it's just food, or it's just big pharma. But no, I'm sorry, you have an oath as a doctor. Why the hell are you even a doctor if all you care about is either money or trends or whatever? Why don't you care about the quality of life and the treatment that you do, right? So to me, that's kind of, yeah. Anyway.
No, I love it. So you mentioned something that makes me want to move on to another topic, because you are an educator. You've lectured all over the world and throughout the United States, and I've heard you, and you do a magnificent job.
Thank you.
And but what I think it resonates with your audiences is really that holistic approach to not just sleep, to dentistry. Before the show, we were talking about, that there are so many organizations that will say, make a lot of money doing sleep, learn how to treat sleep apnea, become a sleep dentist, and well and good if you're passionate about it. But there's a much bigger issue, which is, how does that fit into the context of not just oral health, but overall health? So, in other words, yes, we can teach somebody how to help somebody with sleep apnea very effectively. But what happens when the jaw joints now are, uncomfortable for the patient, when it's really something we should have diagnosed prior to the sleep appliance being made? What happens when the bite changes occur? Why didn't we talk to them about making orthopedic changes that could have helped them first prior to providing this other therapy? I mean, it's just, it's really kind of operating with blinders on when we
Yes.
teach people to be these one-trick ponies.
Yes.
Here, make appliances, make a
Yes.
lot of money, throw acrylic out there.
Yes.
So what I would love for you to expand on is, one, I know I would like for you to expand on how you look at every new patient that walks into your office, that how sleep falls within the context of general practice. Because I think, one of the things that upsets me the most is when people say, well, I don't care anything about sleep apnea, I don't want to make appliances. Well, to me, you can't really practice general dentistry without
Right.
at least a basic understanding
Yes.
of the physiology there. So
Yes.
maybe expand on that a little bit.
Absolutely. So, I want to say there is a way of looking at it ideally, right? But I'm going to talk about in a way that's kind of practical, and how, if you're just, even just doing bread and butter dentistry or just the everyday practice, what I hope that is very plausible and possible to do. And, if anybody were to replay this video or this recording, that they can take home with this in the sense. And I kind of just will go by how I would look at a new patient, someone intake, and what records and what would I do, right? And I'm going to make it as real as possible. So just starting with that. And remember, I want to touch upon, if I forget, myofunctional therapy, as well as of course the other things that are tied from nutrition, exercise, and mental health. Okay, so those things are I'm going to talk about, but I already talked so much that I just want to make sure I don't forget that. So the first thing that we have to do is we have to know, what can I as a dentist best do for the patient when they walk in with their chief concern. Okay, and let's say hypothetically they're coming in for just fillings or routine. Well, it is our responsibility, for if we find a lot of red flags, when we do our screening, or if when your hygienist picks up on red flags, we need to get that conversation going about overall health. And overall health then again ties also into the medical history, the prescriptions, all the past surgeries and whatnot, right? And then put that together. But it's also super important that once we discuss that, we need to find out what's realistic, okay? And also what we need to do in terms of the best outcome that's possible, depending on the patient's um, level of compliance that they're willing to commit to, their finances, the length of time of the treatment. We need to get it out there full, right? But understand also that if the patient, this is America, right? If they don't want to go through a 2.5 year treatment plan, 2.5 years treatment plan, it's okay to do this treatment plan versus that treatment plan, whatnot. So I'm going to kind of just lay it all out in terms of what is the basic, right? So, first of all, if a patient you find red flags have airway issues, right? You needed to get the discussion about a freaking sleep test. Without a sleep test, you cannot say, "Oh, I think I snore. I think I have sleep apnea, or I don't have sleep apnea." Or no, you need to get a sleep test, and you need to work with a board-certified sleep physician to get the official diagnosis. Regardless if they're going to use medical insurance or they're going to be cash fee, it doesn't matter. It's important because you yourself want that information, right? If you're doing all these beautiful veneers or whatever the hell, it's like, why are they breaking, or why is there this issue or that, or why is the implant coming in half? We got to get a sleep test done, right? And we got to do some screening. We got to get kind of that into gear. Now, with that said, then, well, what is the basic thing after a sleep test? Well, if they're severe, most likely the sleep physician is going to push for a CPAP trial. Mild to moderate, there's a lot of not just evidence-based, but there's a lot of new literature and things backing up that oral appliance therapy, okay, which also a lot of people call a Band-Aid, just like a CPAP is a Band-Aid, but there's nothing wrong with that. And let me just, get into that a little bit later.
Right.
But where I'm trying to get at is that we have to look at what are the initial options that we have to address. CPAP, holy cow! Just you and I, we had an awesome conversation at ADSM. There was a beautiful lecture. Now, I was kind of disappointed that not many of the attendees attended that, but there was a Columbia University professor that did a study on angiopoietin 2 cytokine. It's a growth factor. It's a big red flag inflammation marker of heart attacks and strokes. And yes, using CPAP pressure with 7 or 8 or above, that air pressure goes into the endothelial cell linings in the lungs. And guess what? It releases angiopoietin 2. It's meaning that if you use CPAP long term, you can actually create incidents of cardiac hypoxia and heart attack. Okay. So excuse me. Okay. Not only that, have CPAP, okay, with the aerophagia side effects, with certain ones recalled because it blows carcinogens down your airway, happy, as well as there are people who don't clean it well enough and they end up with Legionnaire's disease, like pneumonia, with all that biogunk that they, come in, or the ResMed ones actually interfere with, ICDs, pacemakers, and if we think about AFib and all those things that are now I have a connection with congestive heart failure, et cetera, et cetera. This is very important that we have a come to Jesus real moment about CPAP. And if you use it 7 nights and 7.5 to 8 hours per night as an adult, then great. But most people, even the adherence and the compliance is very bad. So we have to talk about mean disease elevation. We have to talk about apnea burden. We have to talk about apnea load. And those things are very, very important. Okay. And so where we as oral appliance therapy, in customized oral appliance therapy, you just look at the studies alone in terms of compliance and comfort and patients' adherence. We already smoke. We smoke CPAP. All the studies that show, the Boyd studies, they show not only do we smoke CPAP, but people long term, because of it, we're a lot more effective. Now, CPAP is very efficacious, right? Because when you use it, it gets your AHI down to 0.1. But if they don't use it, then you find stories in the media like, Justice Scalia to who knows, Ray Liotta, Scarface to Princess Leia, Carrie Fisher, whatever.
Right.
The sleep apnea issue. So let's just have a come to Jesus real moment with CPAP. What about oral appliance? The oral appliance, because it's the most evidence-based, cited, whatever you call it. So medical insurance companies, of course, and sleep physicians now actually, think, yes, oral appliance therapy is a very awesome and considered alternative to that. So you can use that as a option. However, there is a category, over 20% are non-responders to oral appliance, right? So what are the options there when you don't have that, right? So there are the orthotropics options, there's the growth guidance appliances options, there's expansion options, and that is very, very important. And for me, I want to make the argument that myofunctional therapy, like exercise, should also be incorporated in oral appliance therapy as well. And we can kind of get to that later a little bit, but myofunctional therapy is a very big deal. So when we get into orthotropics, that is still, in my humble opinion, not so invasive, right? So when you get beyond that, then we're thinking about maxillary skeletal expansion too, where Juan Moon at UCLA did a lot of awesome studies. NEMRP, SARP, DOME, those are, sometimes mini implant assisted, where you're actually splitting the palatal suture, you're growing, big time, but this, surgical, more invasive. Then, of course, you can get even more radical and do MMA. And not to knock Inspire down, but, first of all, there's actually a good, in my opinion, thing that Inspire is doing, because it's really bringing awareness about sleep apnea.
This is how many consultations are you getting because of all of the advertising that Inspire is doing?
Exactly.
It's wonderful for us.
Yes, for that. And the thing too is, I've actually had Inspire patients who technically have more fragmented sleep because the zap actually wakes them up, right? So there's kind of that aspect where they're, like you said, like they're coming for, hey, you know what, this is not going to work. I need something different. But then of course, when we deal with all those realms, this is where you and I, before the recording went live, was talking about syntax. Right, so syntax is very important. So syntax is not necessarily addressed with customized oral appliance therapy, or the very first get-go, if you will, or Band-Aid option. But when we start actually growing, changing the bite, and looking at TMJ, looking at orofacial pain, and okay, again, this is also very important. So when that new patient walks in the door, not only did I talk about financial circumstances that are very, very unique, as well as their willingness for compliance, their willingness to do myofunctional therapy exercises, all those things have to take into account. But also, it's very, very important that we look at the what was I going to get to? I'm sorry. I talk so much, sometimes I lost my train of thought. But anyway, okay. So, when we talk about these options, syntax is super duper important, right? Because if a patient walks in, okay, and remember, when it's acute or it's urgent, like if they walk in with a freaking abscess, hello, that trumps everything, right? Or if they have cellulitis, yeah, okay. So if they come in with TMJ pain, migraine headaches, they have strains, they have SOT issues, SI issues, or they have actually, balance ascending or descending disorders. If they need, treatment where they get the squamous cranial sutures released, right, with chirodontics, where you can actually drop and move the maxilla non-invasively. It's been proven. I had it done to me. It freaked me out. But anyway, those options are very important. So syntax is very, very important, because you highlighted on the fact that a lot of times, so many, schools, camps, they want to, number one, make money. So it's okay. That's just the way they are. People want to make money. But in a way, again, I hope that every time they do anything or teach anything, there needs to be that, again, Hippocratic Oath part. And even there's the part, even with oral appliance therapy, I've seen so many dentists, and it's sad. Even in Vegas, I've had cases. I have veterans who came in, and they're more about how many appliances can I make in a month, so I can go and brag and say, oh, I did 100 appliances, so therefore I'm special because this oral appliance company takes me on cruises because I do so many wonderful things and I'm so wonderful. And they don't follow up, they don't titrate, they don't do anything. All they do is sit there and brag. I'm sorry, but those people are harming the dental sleep medicine industry and harming what this is already so precious. Because
100%.
I'm sorry,
I said 100%, and that's, we worked so hard to develop a reputation, of people who care and people who are trying the best thing. And how hard it's been to get in with the medical community, and how many extra letters and notes did we have to write with follow-up, just so that they knew that we were looking out for the patient's best interest and that they were going to get the follow that they would with any other specialist, if not more. You almost felt like I had to overdo it, just to prove my worth in the medical community. So yeah, you're right. It's when there are people out there that are just, how many can I do? And they're not giving that follow up to the patient, and the patient tells their primary care, or the primary care is not getting any information back from you. How's my patient doing? Why the hell would they want to send you anybody else? They're just going to say, no, dentists are just out there to throw plastic in mouths, and go ahead, go get the piece of crap from the grocery store. It's the same thing.
Thank you so much for saying that, because I'm gonna be fair and real about all these academies that we go to, and I'm grateful for all the new literature, the studies, and the contemporary things that need to move the needle forward for what we do. But I get really sick, almost the puke emoji, if you will, when I see these oral appliance companies, when I see all these booths, and their main goal is to kiss ass and say, oh, let's just see what ways we can do to make you have so much profit and have so much, like, I'll take you to a $1,500 sushi dinner, for example, that I heard of. Holy shit, excuse my language, but like, really, just so you can try to get them to do like, what, 10,000 cases a month, and they don't follow through, they don't do what's right, and they don't even think about, what if this patient's a non-responder? What if this patient had side effects, TMJ, TMD, all these other issues, right? So when I see these patients here in Vegas like that, where I'm like, oh my God, like, no wonder, and it's like almost like the type of dentist that when they do things, again, it's always focused on money, 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 money. And no, this is a very serious medical issue, and it's connected to the entire body. So I beg, I beseech people, freaking do what's right, and in your heart what's right. Just being able to make a whole hell of money, but have so many people that aren't treated properly, and then they go back to their sleep positions and they either badmouth the entire industry or badmouth, it hurts us all. So like you said, with the people who work really hard to try to do it right and try to do it thoroughly, it's really, I just wish, there's a whole different, but it's wishful thinking. I know there's politics. I know there's a whole bunch of crud, and a lot of people, actually, honestly, Jeff, you say people like me. A lot of people don't like me because I want to, force myself.
I don't believe that.
No, but I want to, I want to be real, and I want to just, and even if it, if I call something out or whatnot, and I don't mean it to actually make people feel bad. I do it so I hope that actually people will go home, maybe meditate and think about it and actually change. Because just because you did things bad in the past, it doesn't mean you can't change at this point and start doing it right and start, heading towards the light, if you will. I'm not,
Well, and I also, Jerry, I don't want everybody to think like that, if you're doing it right, that other dentists are judging you, saying you're only about the. There are a lot of who want to do the right thing, but they're a certain way, just depending on where they were educated, or who kind of mentored them through the process, and they just don't be better. And maybe I have to sell a lot of appliances in order to be profitable. And the fact is that the more education and the more comprehensive you are, just because someone doesn't do well with appliance therapy doesn't mean that you were not successful, right? I mean, there are other adjunctive therapies that you may be able to offer. And yes, they should pay for your adjunctive therapies and for your education and for your brain. And it's even an opportunity when things don't work out well. Let's say somebody says, I don't want to wear an appliance. Did you fail? No. If someone says, I really want to do CPAP, I'm really worried, and I don't think I'll be able to wear the appliance, and I'm not going to get this dental work done. Well, please, God, go ahead, get that CPAP, get your apnea treated. But here's some I want to think that may lower the pressure of the CPAP. That may make you get better sleep while you're sleeping, because I think one of the pieces that people miss in this industry is they paint it as it's only about oxygen. And there's this whole side of
Right.
sleep quality and sleep architecture
Right.
that so many people ignore. And
See,
you get these you get these docs, right, that they say, you know, okay, you got an AHA of an AHI 5. Let's start a CPAP titration, and they never really even went below 90%. Oxygen was never their problem, other than it woke them up too much. And then what do? They give them something that wakes them up more.
yeah.
You know, so
Right. And you know, and I think you're absolutely right on that. I think though that, you know, as you know, when I was little, I always thought about the doctor as a super smart educator and a person who can take whatever I have and mix it in their brain and to be able to tell me what are the best choices and options. And I think that's absolutely correct. For example, if you know, are to fail CPAP, or if we're going to try, you know, nothing's ever a guarantee, first of all, which is very important. I tell all of my
right.
patients. But moreover, I do think that very initial consult. So my consultations are very, very long, and I'm sorry, but I charge for my consultations. But I'm willing to bet that when my patients, compared to any other doctors who either do the quick free consultation or no charge consultation, because you know you have to think about it. It's just like buffet. If a buffet is all you can eat for $2.99, you got to wonder what they put. Like, do they put horse meat on the buffet, or how
Yeah.
do they, you know, how they make ends meet, right? So, but the consultation or the initial appointment or the new patient exam, whatever you want to call it, is super duper important that you're as thorough as you can be. And if you don't have the knowledge or the training, then either one, refer out, or two, go into different, you know. But I think you have to go into all these different, you know, schools of in these different camps or whatnot, with the idea, of course, if there's any type of equipment or any type of method or philosophy, um, all of them, especially the gurus, will say that they're the only end all be all and everything, right? I've had so much of that going through so many different schools and camps in my life. It's almost,
Right.
you know, they think of themselves as like a messiah or a prophet or something like that. I mean, I'm a joke. I mean, but really, if you think about how they think about their method and their, you know, and you know, so I can't name any names, but all of them, they have that feeling. But just remember, there's so many ways to skin a cat, and there's so many different variability and so many diversification, so many different phenotypes, so many, you know. And again, even sometimes it may not be a health related thing; it could be just financial, or it could be, you know, emotional, or all that. So those things really have to be addressed on that initial consultation, so that in the future it's also very helpful, because if you say, hey, you know what, there's a certain percentage that are non-responders or this or that, at least if you've done everything you can. And that's also very important. You know, what is everything that you can? You know, some people will use a $2.40 gauge and then take 8 seconds, take a bite, and then boom, here's your appliance and bye, and I'll never see you again. Whereas other people will look at 3D, they'll look at cone beam, they'll actually have metrics, they'll have baseline, they'll record that. And you know, there's even some philosophies out there that, oh well, you know, you just save money on this. You come see me. You don't need this equipment, you don't need that. But then again, I'm like, oh my god, like, so what are we trying to do here? What is the endpoint? Are we trying to be a factory where it's just a conveyor belt and it's just stamp, stamp, pop, go, stamp, stamp, pop, go? Or are we saying, you know what, if it was my own mother, my own father, my niece, my whatever, my wife, would I want that? I mean, everybody, when they ask, when it be, you know, whether it be dentists or doctors, of course they want the most comprehensive. Of course they go to Mayo Clinic or wherever to get the most comprehensive, you know, your blood work to everything, to this, whatever, your genealogy. You want to know everything, right? But then, so why are we preaching these really, oh, you know, go cheap on equipment, go cheap on this, go cheap on that? There's a cheapness for a reason. Just like if there is a $2.99 buffet, folks, people are not going to, you know, get probably fresh organic quality chicken on their buffet, you know. So anyway,
No,
you know,
I love what you said too, because and that's something that I've learned, because I've made every mistake one could make along the journey in sleep medicine. And one of them was this thing that I had to do these free consultations. I'm like, no, I'm literally, from the time these patients walk through the door, we're going to spend up to an hour with them. They are going to leave with a comprehensive diagnosis, not just about their airway,
yeah,
but their overall dental function. And so, I mean, we're going to talk about the joint, we're going to talk about the airway, we're going to talk about their function in general, and then we're going to talk about how it affects their overall health. And you're right, you can't do that without charging for it. And you know what? No one ever looked at the fee for an exam like that for the exam. And not only that, I think the conversion rate is vastly improved when you give them that kind of time versus a 5 minute, oh yeah, we can fix you, and I say that about hygiene visits as well, that comprehensive exam shouldn't happen in 10 minutes in the hygiene room. I mean, it's not that it's in the hygiene room, that's not the problem. It's that
the time
just quality time with the patient.
And I have to say, for the last of my entire career, I've never had done an exam in the hygiene. But again, you said it's fine in the room as long as you do a very thorough assessment. And I'll tell you, patients, they really, and that's how, honestly, if you want to build your practice, everybody says that word of mouth is the best. I mean, if they go to their primary cares, especially if they have HMO or they are in the factory system, they're kind of used to that. And even like I have stories sharing about my own, parents, when they went to the doctor, how long they had waited, then the nurse finally gets them, and they only get like 5 minutes with the doctor, or even less sometimes. They write a new prescription and boom, you're out the door with a $400 fee. And if you don't have insurance, that could be quite a bit for just 5 minutes of the doctor's time. But then they shovel and funnel so many patients through in the primary care model in America. Well, wouldn't it be refreshing then if they go to us as a dentist, right? As a dentist, and we can do something to be the game changer, hopefully, to say, you know what? Oh my God, like the person that actually connects everything together for me and looks at me holistically and ties in my blood pressure medications to my gout, to my fibromyalgia, to whatever, connected to my oral health, my sleep. I mean, I just don't want to say this, but this is a thing to pat our back. We dentists are kick ass. Honestly, we do so many.
Agree.
People, they come in, they're afraid of needles, they're depressed. We put on so many freaking hats. I mean, we don't have any degrees in psychiatry or psychology, but yeah, we're also, many times counselors. We're also, and then if we are, physically fit or whatnot, we also, talk about how we got there. We shared nutrition and people can relate. And it's so, I think really as dentists, we're so remarkable, but this is also a very, very big kind of, like a big green light for us, if you will, that we can hopefully even change healthcare. And we can't do that alone. We got to get more and more people thoroughly united. So, I want to just give some of the pros of what I do, just in case, like, so we're a complex case. So let's deal with the complex case. A new patient walks in, they have oral facial pain and TMJ and all of that. Okay. So we need to discuss a orthotic or some type of issue to address. Of course, the more scans, the more things you can find out. Is the disc displaced with reduction, without, the popping, the clicking, if there's no popping, clicking, if they're on bone to bone. I mean, those things are very, very important, right? And then we want to facilitate that, because that syntax is very, very important, because you start expansion, all these things, and you don't have a clue about TMJ or TMD, or you don't have a clue about nathology or occlusion. I'm like, okay, that's going to set yourself up. And especially when these big cases are orthotropic. And also during the finishing of those cases, it's very, very important. And it's okay to plan it to where if you're doing those things that you do know how to do, you do it. But if you don't, you can refer to an AO or chiropractor, SOT chiropractor. Finishing the cases, you can refer to many functional orthodontists if you don't like to do, braces. But there's also Invisalign, Candid Pro. There's a lot of airway-centric orthodontic clear aligner options. I know that at Stanford Medical and Audrey, they're doing a lot of Invisalign studies, even for expansion and things like that, right? So there's a lot out there, but it's very important then. Okay, so if I have TMJ pain, if I have those things, remember they're acute, so they fall first on the list. So now if this patient came in and they had so much severe compensations as well. They have SI issues. They need a SOT chiropractor. They maybe to wear a trochanter belt or special type of underwear, core wear underwear, or if they have one leg longer than the other leg and they need to have a foot orthotic or whatnot, those things can be referred out and addressed in initial. And I promise you that there's not enough, well, you can't really have randomized controls on this, but there's not enough meta-analysis. But I've seen if you are more symmetrical and if you align and you get the chirodontics, if you will, done at the right stage, the right syntax, the growth and expansion actually happens way faster. The body wants to be in balance. The body wants to be even. So if you can address those asymmetries, whether it's a side bend or an AP strain, those can be done non-invasively by releasing the squamous cranial sutures. And at AADSM, I asked, especially during the pediatric pre-4 day, I asked a lot of questions about this. People are like, I don't know how to answer that. I don't, but so this is, again, you have, physicians, orthodontists, pediatric dentists, pediatricians ask these questions, and it's just like, they don't know anything about it. So again, education, and, going out to learn how we do things and improve upon them. Then after that, again, will be the expansion, right? So the expansion, you have to then have that moment of talk with patients where if you want something that maybe is really biomimetic, and also at the rate of the patient's own expansion. I mean, because everyone's their own thing, and you don't know until you are, gonna go into it. The rule of thumb I look at is anything that's fast, and again, it's very logical, does run higher risk of relapse, inflammation, dehiscence, or bone loss, or root resorption. Okay, so those things, if you look at rapid palatal expansion, a lot of times when you see orthodontic cases that are completed, you look at these anterior teeth and the root size are half their, you can actually see the outline of what the root would be, but that's actually bone. Because the roots just right. So you have the idea, but then of course there's a catch-22, right? The slower appliances that you look at will have that compliance issue, that compliance risk.
100%.
Yeah, and so those, because if you have a 2.5 year treatment plan, you have a 2.5 year treatment plan. If they on year 1.5 or 16 months and they're like, forget it, this is taking too long, then holy crap, all that money, all the effort, all the myofunctional therapy, everything that you did is just going to throw out the window. So those are really important discussions. But then of course, patients like, well, I don't want anything invasive. Or I don't mind anything invasive. I want things to be fast. Then okay, I mean, you can even go to MARPI, SARPI, DOME. There's plenty of evidence based to support those. And can those go wrong too? Yes. I developed an orthotropic series of slides, a seminar thing too. And I'd like to show yes, not everything again can be guaranteed. Not everything is invincible. There are definitely actually screws, implants that can kind of be bent sideways. I've seen a lot of mastoskeletal expansion cases where they weren't ideal, or the growth was lopsided or anything, so there's those things as well. Then after expansion is where you kind of hit on the very, very beginning of our program here today, was the finishing of the cases. Oh my God. Like there's so many like schools and camps that just say expansion, then you're done. No, you're not done. There has to be occlusion, there has to be aesthetics, there has to be function, there has to be harmonious as best you can, because sometimes people may have a very difficult, especially if they have a fan face and they come in with TMD issues, their bodies are already been compensated so much. And so those are more kind of complex, tougher cases, if you will. But like, it's very important that people remember the finishing of the cases. It's like not putting the frosting on a cake. It's not having, it's just only having the meat at Thanksgiving, but where's the bread and mashed potatoes and where the cranberry sauce, all that stuff. You got to finish the case. It's really, you talk to any orthodontist, right? They have photos and cast and models of before, they have their lateral ceph tracings, and then they have after with all those things, right? That completes a case. So finishing the cases, there's many options. There's, of course, a controlled large ortho, or just a simple ortho, straight wire, whatever you want to do, or there's clear aligner options. And then again, what about the other things too, right? Earlier you touched upon, well, I don't want to do oral appliances, or I don't want to do this, that. Well, there's also just simply myofunctional therapy or lasers. If you have a DECA laser or CO2 laser, for example, you can actually do a lot. There's a couple of procedures that, again, there's more evidence based now, that instead of a UPPP, it actually, because of the certain wavelengths patented, for example, in a DECA laser, I'm not like, I don't get any money for saying that, but for what it does is it stimulates collagen and it firms up that soft palate, vibrating line, those soft tissues. And actually, on average, 2 to 3 treatments, if you just look at that, has been shown to reduce apnea-hypopnea index. But
Absolutely.
yeah, I also want to get a little bit on the apnea-hypopnea index. Just for people who are more new to this, oh my gosh, you and I know, Jeff, we agree with it. AHI is just a freaking insurance number. There's so much more to that. And RDI is already better than AHI. But then again, we talked about those things where you touched upon, where there's loop gain, there's neurological abscess, there's everything that we do, from our habits to our diet to our exercise, and again, mental health. I cannot underscore right now, because I know earlier we kind of joked a little bit about depression, things like that, but holy crap, Jeff, because let's say you had anxiety and depression. You don't think that's going to create more fragmented sleep? It absolutely will.
Of course.
Yeah. If you wake up, if you have a little bit of insomnia twisted with all the sleep apnea, hello, at 2:30 a.m. in the morning, and you're freaking depressed, the world just, falling. Yeah, that's not going to get your health, like when we talk about us, and I'm really glad that you said it, because I honestly look back, it's not that easy. I mean, I worked out, got my black belt, but through those times, and especially again through that black belt, it was hell. But I kind of wanted to just do it because, again, what empowers me is I feel like there's some kind of weird, like, Jerry here has a calling, and God wants Jerry to, be an example to, but then, of course, of course, the chocolates and sweets, I have a sweet tooth. Yes, but also I think that's very important too, because sometimes just balance in life is really key, right? If I was on paleo, or if I was on Atkins all the time, and yeah, I wouldn't look like the way or have the energy that I have right now. I know for sure. So okay, so that's sort of my going around where, but I want
Love it. And I let you go over because you were just on too much of a roll for me to stop you. And that's just such great information for everyone out there to have. We're going to have to close it up because we've gone over just a few minutes, but it was absolutely worth it. Everyone out there listening, if you've not heard Dr. Hugh speak, please find him where he is lecturing. Look him up. What do you have a website they can look at?
Well, I'm starting this new. So I put it on my Facebook, and I put it on my.
Okay.
So there is a wonderful friend of mine here. He has a big state-of-the-art clinic in Vegas, and we're going to try to do, because all these years, and you know this, Jeff, we either did it for an industry or a company or whatnot.
Right.
I'm just kind of done with that, and I'll just speak truth from my experience and all the stuff that I've went through, and really give all the tools. Here you go, me open, nothing guarded, nothing hidden, no agenda. And so I want to kind of create that brand for myself. So it's
you got a place in Myrtle Beach that you can come to as well, because so we'd love to have you speak. But for everyone out there, if you've not heard him speak, please do. This guy has 5 intellectual patents. He's written some landmark articles. And Jerry, what an honor that you joined me tonight. I'm so glad we got to have this one-on-one. And I'd love to have you back again because I want to talk about some of the controversies in sleep apnea. Some of our most listened to and most viewed episodes have revolved around controversies. And in the world of sleep medicine, there is certainly no shortage of controversy. So I'd love to have you on. We can talk about that again. In the meanwhile, everyone out there, thank you for joining us. Be sure to keep listening. Get us wherever you get your podcast. You can watch us on Insta, on Facebook, on YouTube, and what a pleasure it is for us to bring you people like Dr. Jerry Hugh. So Chad, JB, missed you tonight, but in a selfish way, I'm glad I got to have you to myself, Jerry.
Thank you. Thank you so much, Jeff. Your brother to me.
Okay. And everyone out there, have a great night.
Thank you. Bye-bye.